I'm
Hi.
David Cohen from St. Francis Hospital and Cardiovascular Research Foundation in New York, and I am one of the moderators of today's session of Asia Pacific Valves. My co-moderator is Vinny Babat from the Minneapolis Heart Institute. We have a terrific and very geographically diverse faculty here with me. We have Dr. She from Taiwan, Dr. Kumar from Delhi, India, Dr. Yoon from Cedar Sinai in Los Angeles, Dr. Hong from Korea, Dr. An from Korea, but joining us from San Francisco, and Dr. Flaherty from Chicago. So we have a great crew, and we are looking forward to two what sounds like very interesting cases. And so I see the cath lab is ready at Asan.
All right.
Is that Dr. Park?
Hi. All right. Great. All right. As we first of all, I'm very happy to meet you all. Even in the screen, it's the very tough situation. Today, actually, we'll change some topics. Valve special virtual session to the bicuspid TAVR procedures. So we are actually preparing two cases, and we are very proud in terms of we have very strong heart teams in terms of TAVR procedures. Do Yung-gang and Dr. Lee and our faculties and anesthesiologists. Actually, for particular these cases, we're gonna do in terms of minimalist approaches. We don't do the general anesthesia and just all right. And the first cases, Dr. Gang, would you explain that case first?
The patient is 73-year-old male patient and referred our center for treatment of severe AS. He had dyspnea on instruction and near class of the 2 or 3. And his echocardiogram showed bicuspid aortic valve with very severe degenerative aortic stenosis. Next. And his STS-PROM score was 0.7%, very low risk patient. And he does not have any previous medical history of cardiac disease. Next. And ECG showed the LVH pattern with sinus rhythm. Next. And chest X-ray showed cardiomegaly. Next. And this is his coronary angiogram that showed intermediate stenosis with prong rupture at mid-LAD, and FFR shows 0.80. Next. And this is his echocardiography that showed normal ejection fraction and severe degenerative AS with severe AR. And peak and mean pressure gradient was 146 to 82 millimeter mercury, and peak velocity of the aortic valve was 6.0 meter per second. Next. And TE also showed functional bicuspid aortic valve with severe AS and severe AR. Next. And this is our comprehensive CT analysis of the aortic annulus view. They showed in the annulus short diameter was 24 and long diameter was 27.9 millimeter. They showed annulus area of the 529 square millimeter.
Would you discuss the type in terms of bicuspid?
Next slide shows very well. In the sinus valve, you can see that the beginning point of the valve has the tricuspid, but at the sinus valve level, the RCC and NCC shows some fusion, and NCC and LCC shows some fusion. That is showed in echocardiography as a functional bicuspid valve. And I think that this is the kind of the type 2 bicuspid valve with the fusion of the NCC to RCC and NCC and LCC. And sinus of annulus area ratio was 1.8, a little bit smaller than another bicuspid patient.
Actually, 2 LAFs, right?
There are 2 LAFs.
Right coronary and even, okay.
Yes. And ST junction was clear, and LVOT, there was no severe calcification in the landing zone of the valve. Next. And the total amount of the calcification was 641 cubic millimeter, and it was not very high in the bicuspid aortic valve. Next. Yeah. Next.
600.
Yeah.
Very much.
We also checked the coronary height. There was over 60 millimeter in LCA and RCA, and we think that risk of the coronary obstruction is low. Next. And this is the peripheral angiogram that shows the very small caliber in the right iliac artery. So we chose left iliac approach, left femoral approach. Next. And this is a sizing chart for the Sapiens 3 valve by the annulus size. And with a 26 millimeter valve, we can achieve the 98% area oversize because of the bicuspid valve morphology and the moderate amount of calcification. We chose to implant valve with a 26 millimeter plus 1 cc to achieve about 3% oversizing of the annulus area.
So almost same, area of size.
Yes.
Meaning is when we choose the Sapien 3, actually we choose the area oversizing 10 to 15%, oversizing. However, for particular this bicuspid valves, we're going to choose a little bit lower, smaller size, area oversize, and it's almost the same with All right, what is next? And so we're going to choose the Sapien. We have some discussion point, right? Before the TAVR procedures. Anyways, we have some. Would you show us coronary angiograms before in fact, all right, that is with the portion of intermediate stenosis is by visually angiographically ruptured plaque, and we have already performed the FFR is 0.8, something, just cutoff value. So what would you do that? Is we're gonna before the TAVR procedures, we're gonna have some consideration of a treat on not to treat for coronary regions.
Should we ask the panel? So I mean, around, is that now a good time to do that?
I mean, the patient is 73, and this lesion is quite significant, right? I mean, this is going to need some intervention. So I don't know, what's the risk of doing it now? There's none.
Not much, I don't think. Is there anyone on the panel who would argue strongly not to treat this lesion?
It also has an ulcerated appearance, so it may be more acute despite the borderline FFR. So I would opt to treat. I agree with you.
Mm-hmm.
Yeah, I think so. What did you decide, SJ?
All right, Dr. Han, what do you think? Would you tell us about the FFR value 0.8? Actually, there's not too much data about that. However, in tighter stenosis, actually very severe aortic stenosis, in those cases, actual FFR value to be, we have a still controversial data. However, a little bit measured in terms of 0.8, and so I think is visually ruptured plaque, and 0.8 something is a little bit underestimated. And so, Dr. Would you give us some comment on that one?
I think it's a very interesting case. If a patient don't have a severe AS, I prefer to differ under the medical treatment. But in this case, yes, as they mentioned already, the FFR value in severe AS would be number would be overestimated because of microvascular dysfunction associated with severe AS. So in the normal condition, FFR value could be less than 0.80. So less than 0.80 means that coronary stenting would be justified. In addition, under the medical treatment, there would be a higher risk of urgent revascularization. So we have to consider that the urgent revascularization would be not easy after the TAVR procedure. But yes, Sapien 3 would be better than Evolut, but after TAVR coronary intervention is not easy. So I think my personal opinion is the stent first would be a good option in this case.
All right, so we have already done, stent procedure. Dr. Gang, would you explain very briefly, including the obvious findings?
Very briefly, we checked the IVUS, and the IVUS showed a plaque rupture, and there's not so much amount of the plaque, but there was some calcification, as you see in the angiography, and there was some plaque with the flow limiting. So I implanted 4.38 stent to cover all region, and after 4.5 NC balloon, and this is the result. And I've showed good stent position and good flow expansion.
Okay, great. Move on the TAVR procedure, right? In some limited data, in the positive FFR, in case of a severe aortic stenosis, positive FFR value, if not treated that one, after the TAVR procedures, the value of FFR worsened, right? Tended to the worsened. The meaning is the 0.8 FFR value is underestimated in case of aortic stenosis, right. And so we don't hesitate to treat for particular this region. All right.
But so I think here you have highlighted also the fact that it's not just the FFR value, but IVUS was very useful in making the decision. Is this patient had gone for surgery, he would get a Lima to LAD. No surgeon is now going to leave this alone.
we have lots of discussing point, IVUS and FFR, right? All right, all right. Move to the TAVR procedure. So what do you think? We choose actually we've shown a lot of CT algorithm data, and we choose the SAPIEN 3. And so we're gonna in terms of a type of because the aortic stenosis is quite I think as usual. So aorta size is good.
Yes.
However, still sinus ratio is relatively small. Anyways, there would be some debate in terms of balloon expandable, self-expanding. David, what do you think?
I think when you have coronary disease, I still am not a big fan of covering the coronary right off the bat with a self-expanding stent. So if you have coronary disease, you revascularized, this patient has higher than average risk of coming back sometime in his life or subsequent coronary revascularization. So I would like to preserve the best access to the coronaries as possible. So I think a balloon expandable would be just fine here. The anatomy is not that unfavorable, but I think that this is where I would like to stop for just a second and ask Dr. Yoon or Dr. Kumar to comment on the anatomy and the approach with a bicuspid valve of this sort, with two fused, partially fused RAFAs.
Yeah.
Dr. Yoon?
Hi. Thank you for the opportunity, Dr. Park and all the doctors in Assam Medical Center. So this is a very interesting case, type 2 RAFA. So there's a very limited data. I have seen a few handful cases. But assuming the RAFA between right and non-coronary, the RAFA has the extensive calcification. So, and then the RAFA between left and right is basically the fibrotic. So we assume that can be expanding. So the problem will be the RAFA between non and right RAFA. So this is not the easy case, that's for sure. But then the size is 500, area is 560. So 26, I think the Assam strategy is 26 millimeter device plus 1 cc. I agree. And can be just nominal 26. If you feel resistance, the second operator, if you expand, and if you feel the resistance, then I think we can stop. And then we can add post dilate. I think that's the safest way, and we can get an optimal result. That's my feeling.
Thank you. That is an excellent comment. So is there anybody interested in pre-dilating this valve to make sure that it's going to expand? Is that, would you do that, Dr. Yoon or Dr. Park?
Yes.
Will you pre-dilate, SJ?
Yes. So actually we have no clear cutoff. So what cases actually we're going to do the balloon pre-balloon inflation, something like that. However, we have some average calcium amount in our hospital is almost 400 cubic millimeters, something, right? And so if the calcium amount more than that, actually we're gonna do the balloon pre-dilations, some expansion. We don't too much concern about the size of the balloon itself, but just cracking to break down the calcium force. And so we choose the 20 millimeter balloon, relatively small size. And so, okay, we want to do the balloon first. And so we have already equipped support wire. It's not
if you do the pre-dilation, please take the angiogram simultaneously, checking the movement of the calcium into the left coronary ostium. So we can evaluate the status of actually on a fluoroscopic image, the calcium might be the move to the ostium of the calcium, the left coronary ostium.
All right. Good suggestion. So we're going to do pigtail and there's more D4 and non-coronary calcium here. Test, please.
Yes.
Okay. Balloon in the mid portion is a pacing. That. Okay, good. Pacing on contrast. Okay. Inflate. Fasting. Oh, no. Deflate. Okay. Pull in. Okay, more. Just.
And what balloon do you have, SJ?
20. What balloon?
20 millimeter.
20 millimeter. What balloon?
I think using the undersized balloon is not going to give you that much. The patient already has
contrast. Inflate. Good. Inflate.
You can see here that the balloon is moving in one direction.
Okay.
So what do you think of that, Vinny? You okay with the?
So my concern, as Sungan actually rightly pointed out, is there are two commissions which are calcified. So was effectively
Picture,
going to
balloon
expand only
inflation.
in one direction. And you saw that very well on the balloon, that it moved completely just on one direction. So I would be very cautious because
It's going to go straight to the left cusp there. Yeah.
it's going to hit
Right.
the aortic valve.
Okay. Okay.
So does that
Right.
concerns you a little more than for potential occlusion, I guess?
All right. So
Even aortic injury, I think.
we choose the 26, the one saying the 1/6 of appeal. Dr. Yoon a little bit worried about that one, so I don't know what happened. I don't know what it is. However, the calcium amount in case of bicuspid aortic stenosis relatively, small, not too much, medium size. And so we're going to choose the little bit, bigger, 1/6 more. All right.
Are you going to deploy this?
You have to,
You mean in the normal position, or are you going to deploy it high? Where will you deploy this, Esther?
I think essentially you will have to cover the leaflets, correct? The worst thing to do is deploy it below the leaflets here. So let us see what SJ does when.
Yeah, I don't think you can go too low. Yeah.
So, Dr. Vijay Kumar, in India, if suppose this patient presents is 73, extremely low risk, a bit challenging anatomy with LAD disease, should this go for TAVR with PCI or surgery?
다시
You're on mute.
Dr. Kumar, you're on mute.
Okay.
Dr. Park, I have a short question. How about hemodynamic blood pressure?
Sorry, 73 years and a low risk. India, because the insurance policy is not very prevalent, these patients can be easily handled by the surgeon also. But these days, because TAVR is becoming popular, many of the low-risk patients, even if they are self-payers, they approach for TAVR.
Okay.
And TAVR is done along with PCI on the same sitting. But one thing about the pre-dilatation, Dr. Bapat, I would say that bicuspids would, by default, they should have pre-dilatation, and a good pre-dilatation should be done. Yes, if there is a calcium in the raphe, we should be careful that we don't rupture the calcium.
Very good point.
So shall we perform the autograft again before we deliver the
pressure?
In this case, because I have existing article registration.
Just please. All right. What do you think? I think it's good. The central dot is a little bit lower. So however, the stand place actually a little bit slow higher. Contrast again. I think it's
this
good.
is a great solution because
that's great. Facing. Contrast again. Okay, good. Inflate. A little bit fast. Good. I like this position. 3, 4, 5. Okay, deflate. Deflate.
So as was predicted by Vinny, the valve is right up against the left coronary there.
Yeah.
All right. Actually, pick their place in the low part of our non-chronic test. However, I think it's okay. And leave the.
Can you show the hemodynamics? Can we see blood pressure and things?
Okay.
Good.
I want to pull the system out a little bit further. All right. Here we are. Just give me one here, please.
Does anybody worry more about trapping the pigtail in a bicuspid valve than in a regular valve? We trap it all the time with regular valves. But does that concern you, Vinny, at all?
I think the sinuses are so wide that.
I mean, I don't think it's. I mean, I think it's pretty easy.
Yeah.
I mean, there still are a lot of people who don't like to trap the pigtail at all.
Yes, sir. Okay. Because. 천천히. A little bit pulled out, a little bit further. Wires, and I want a picture first.
You ready?
Okay. Yeah. Sure.
Wow. Yeah.
Oh, what do you think? I think it's good.
I mean, I think you don't have, traced
All
in
right.
mild AI, I think. I mean,
I
it's just,
think
I mean,
it's good.
it's
So
very
I can
interesting
do-
to see how displaced the valve is. It's not at all in the center of the orifice. It's the calcium in the non and right, I think,
Okay.
is pushed it way over there.
So
But it looks
picture,
good. I
right?
mean, the hemos look good. Will you check a gradient?
All right, so we're gonna check the gradients in the picture in the LB first, and then I'll finalize the.
So I want to just ask a few of our panelists. So we talked about Dr. Kumar about this type of bicuspid patient. So let me ask Dr. Flaherty. So in Chicago, if you have this is a very low risk patient with single vessel coronary disease, not the simplest of valve anatomies. What discussion would you have with this patient who comes to your valve clinic? How would that go?
Okay.
We would still recommend in a younger patient at low risk, we'd recommend surgery.
Sorry?
But he's 73, so we kind of use this 65 as a cutoff for letting the patient make an informed decision. So I think TAVR PCI, even in the US at a 73-year-old for this case, is not unreasonable.
Would you try to, advocate for one or the other, or you'd let it, obviously
go over pros and cons and help them make a decision. I think either would be okay.
Vinny, what about in Minneapolis?
I like it. Did you see the pressure monitoring? So simultaneous delta and LB. No AR index is perfect. There's no pressure gradient. And I want to pull out.
Can't beat the acute results. That's for sure.
All right.
This is a great result for sure.
Thank you. And we're gonna do.
So Vinny, in valve clinic in Minneapolis, what would you tell? Would you tell this patient either or would you try to push?
I think in both, I think in Columbia or in Minneapolis, this patient would have gone for surgery. Patients are sending out eyes a bit dilated. I think if we're thinking of lifetime management, I personally think that would be a better decision. Because here we have now put a 26S3, which will be fine for this patient today. But if you look at Korean life expectancy, which is around 86 years, this patient is going to not be suitable for another TAVR. The TAVR is already on one side. I think surgery would have been better. Not because I'm a surgeon, but I'm thinking of lifetime management.
Okay, we're gonna take a picture.
Anybody remember the size of the ascending aorta?
Ascending aorta size was 44 millimeter. It was not so large. If it was dilated, we would consider surgery. Yeah.
So my question is to the panelists is, if you had cerebral protection,
I think it's too close.
Would you use this in these patients? Because we're doing BAV, it's calcified, it's bicuspid, and in bicuspid, the risk of stroke has been shown to be higher.
Absolutely, we would use cerebral protection in a case like that.
All right, I like area view, right? Not too much,
I don't see no leakage.
And so. All right.
That's beautiful.
And we almost, finalize our procedures. Simultaneous LED stent procedure and bicuspid, maybe type 2, right? And we're going to choose the Sapien 3 balloon expandable, the 600, cubic millimeters, and not moderate calcium. We're going to choose almost the area of sizing, same one, 100%, 0% area of sizing. And so we have a quite, acceptable result, right?
It's a beautiful result. So we've all been talking here about bicuspid valves and just what the approach is and how you talk to the patient. So tell us about bicuspid valves in Korea, SJ or Dr. Hong, anyone who wants to. Just is it accepted to do TAVR in a bicuspid valve? Is it more is it a very difficult discussion? How does it work in your country?
All right, maybe Dr. An have some data about in terms of selected patient group bicuspid aortic stenosis and compare with the registry data, the bicuspid, balloon expandable, tricuspid is almost, equivalent. However, we're going to choose the very, cautiously in terms of a TAVR candidate. And you know that there are more, characteristics of different, morphology in the aorta, horizontal, aorta, heavy calcifications, sometimes, dilated, ascending and sinus area. And so we choose to very carefully. In much tough cases, we send the patient to the surgery. So, not too much, hesitation. And so the reason why selection of cases from bicuspid so far, we're going to have a quite equivalent clinical outcomes between the two different aortic stents.
Actually, in our lab, is that we have experience of the 10% of the bicuspid valve, and around the 10%, and most of the important selection point is the severity of the calcium. If the heavy calcium, we prefer the surgery when the patient age is young. And the second point is the size of the aorta. What I mean is that the patient is age is the middle 70, and the heavy calcium aorta size is more than 50. Maybe low risk patient surgery is a more better clinical outcome than the TAVR. So usually that case is number one recommendation is a surgery. If the patient and their family refuse the surgery, and then plan B is the TAVR. And actually, when we look at these cases, it's a functional bicuspid valve, actually fusion of the aortic valve, not true type 0 bicuspid valve. So what is the finding in these cases? Severity of the calcium is not so severe, and the size of the aorta is not so larger. So in these cases, the procedure itself is perfect. I like it. And the best result, one point is this is a functional bicuspid, not true bicuspid. So a little bit the bigger size might be acceptable. 29 might be.
You mean, the process is good, however, selection is perfect, right? Well,
yes.
All right, great.
I agree. Totally agree with your procedure and the patient selection.
Great. That's your point.
Particularly in these cases.
Hi, Dr. Wang. All right. You want to move to the second cases? All right. Okay. So very limited time, and so Dr. Dogubag will wait second case, right?
Thank you for a wonderful demonstration. That's great.
That's a great case.
Okay, hello, and the audience and ladies and gentlemen, and welcome to this year 2021 AV Valve Structural Heart Meeting. And we prepared very interesting and very challenging live case demonstration, and I hope this case would be helpful to increase your knowledge about complex TAVR procedure. And before starting our live case demonstration, I'm going to introduce the excellent teamwork and our team. And I'm D.W. Park from Assam Medical Center, and Do-Yoon Kang, our junior staff in Assam Medical Center, interventional cardiologist, and Professor Ho Jin Kim, and she's a cardiac surgeon, only one cardiac surgeon having proctorship in our nation. So. Okay, and this case is one of a very complex case nowadays. A couple of months ago, and there is a very big guideline change. Is indication for TAVR the expanded to low risk population, age is more than 65-year-old at this moment, and I think interventional cardiologists already recognize the valve-in-valve procedure would be one of the next landscape for complex TAVR procedure. Okay, so and we prepared this valve-in-valve procedure, and our Professor Do-Yoon Kang will slowly and in-depth review the patient background and the prior history. Okay, Professor Kang?
Yes. The patient is an 88-year-old, very old female patient and admitted for worsening dyspnea from a month ago. She underwent TAVR with transfemoral approach in 2013. 8 years ago with Sapien XT 23mm. And she was regularly checked, and her echocardiogram showed severe bioprosthetic valvular aortic regurgitation with mild left ventricular systolic dysfunction. And she also received a coronary stenting 12 years ago at Circumflex and RCA. Next. And we checked her STS score, and the STS predicted mortality was 7.8%. And she also has the chronic kidney disease with a stage 3. Next. And her echocardiography showed severe eccentric valvular aortic regurgitation. And the peak and mean pressure density was 25 to 11, and effective orifice area was 1.4 square centimeter. Her ejection fraction was 47%. And we checked also coronary angiogram, showed patent previous stent and mild coronary disease. Next. And this is the CT analysis of the index TAVR procedure 8 years ago. Her aortic annulus area was 430 square millimeter, and the annulus area driven diameter was 23.4 millimeter. So we implanted Sapien XT 23 millimeter in the nominal pressure.
At that time, is 23 is just 96.4% area oversizing.
Yes.
Okay.
Yeah. So I think that it is a little bit undersized. Next. This is the index TAVR procedure
8 years ago.
video. Yeah,
Okay.
8 years ago. And you can see that the result is okay, but there was a little bit regurgitation. But it was 8 years ago, and it was very early period of the type procedure, and we were satisfied because the patient was 81 at the time. Next.
This is a Transatlantic Echo.
Yes, Transatlantic Echo at 8 years ago.
8 years ago. At that time, it's just a trivial paravalvular leakage, and the valve function is okay.
Yes.
8 years ago.
Yeah.
Okay, go ahead.
And next, and she was followed in the local hospital and came back to our department after previous month. And you can see the development of the cardiomegaly with the pulmonary edema. Next, and we performed the heart failure medication, and she was a little bit stabilized, but echocardiogram showed severe valvular AR. And Dr. Lee, our echo specialist, will show you the movie again. Next.
Okay.
This is the TEE image that shows severe AR. Next. And this is the previous Sapien XT version. 23mm has the frame height of the 14.3mm, a little bit lower than Sapien 3 version. Next. And we also checked the CT at this time, and you can see the Sapien XT structure, and the valve inner long diameter and short diameter was 21 and 19.5 millimeter, with the inner area of 326 square millimeter. Next. And you can see the sinus of valsalva and SD junction size is okay. Next. And in LVOT area, the strobes were attached to the LVOT. Next, without severe calcification. Next. Yeah, you can see the valve shape. Next. And another important thing for the valve-in-valve procedure is the risk of the coronary obstruction. So we checked the coronary height from the previous valve, and the coronary height was 13 millimeter for the left coronary artery and about 15 millimeter for the right coronary artery. And we also checked the virtual stenting of the virtual valve, and the valve to left main coronary opening, the distance was 4.8 millimeter. That means that the low risk of the coronary obstruction after valve-in-valve procedure. Next. Yes, this is the previous valve to coronary opening height. It was about 5.5 millimeter, sufficiently high. Next. And this is the virtual valve shape, and the risk of the coronary obstruction would be low. Next. And this is the image that we firstly there was suspicious valve movement and migration, but the angiography shows that the location of the valve is similar with the first implantation. And next,
left part is the previous 8 years ago.
Yes.
This is the same angle.
Yes, a similar angle.
Similar angle.
Yeah.
Okay.
And we also checked the CT
scan.
serial
Okay.
CT scan,
Okay,
and the position. Next,
okay, next
position
one.
of the valve was not so different from the 8 years ago and now.
This is a 2013 left one.
Yeah.
The middle panel is a 2017.
Yes.
Right panel is 2021.
Yes.
And the position of the valve is the same position.
Yes,
There is
exactly,
no
yeah.
downside movement.
Yeah.
Okay.
Next. So the Sapien 3 sizing for current CT analysis means that with the new Sapien 3 23 millimeter, the area oversize will be 25%.
Okay.
So what would be the good size for
So
the patient?
at this moment, and most of interventional cardiologists doing the TAVR procedure very familiar in the Bicuspid, the valve-in-valve web. So, but unfortunately, previous Bicuspid valve-in-valve web has a lot of information about the prior surgical valve, but don't have any information about the TAVR valve. Not yet, not available for how can you depth and how can you sizing about the valve-in-valve is a prior the TAVR case. So, at this patient, and usually we do nowadays more than 95% doing make procedure and not general anesthesia, monitored anesthetic care, but this patient we should require a TE evaluation, pre and post, immediate post the TAVR procedure, and Professor Sung RV and the standby. She is now doing the Transatlantic Echo. Okay, Professor Lee, could you in depth provide any anatomic explanation? What is the main mechanism of AR for these patients?
Yeah, this is the general axis echocardiographic image, and we can see the TAVR valve, and we can see the 3 leaflets, and there's not the degenerative change is not so severe, but we can see the tear of the leaflet and the large AR flow.
Prior TAVR valve was tearing is the main mechanism, right?
Yes, I think the main mechanism is from the tearing of the leaflet on the right coronary side, right coronary sinus side. And when we measure the amount of the AR, we measure the vena contracta, and the level was 7.4. So it is so severe AR.
Is AR looks like some eccentric AR, right?
Right.
So what about the PVL, paravalvular leakage?
But I can see any paravalvular leakage here.
The main mechanism
Yeah,
is
the main
prior
mechanism is-
valve deterioration.
Right.
Yes, the valve tearing.
Tearing.
Yeah. Is it? Have you seen similar cases over the time? There is some valve tearing after insertion of TAVR valve.
No, I think it is first case, but we can see the tearing of the leaflet in tissue valve. Yeah.
Okay.
Okay. Right. I got some simple questions.
yes.
Actually, I did the first procedures of a particular this patient. Would you have any information about the CT at 8 years ago, just before the procedures, calcium amount and size-wise and area of sizing, Dr. Gang?
Okay.
Do we have some
아까 사이징 처음
very
했을 때
much, first?
At the first procedure, the calcium amount was very low, about 200.
200?
Yeah, and
200?
previous, yeah. And the size of the valve was a little bit undersized with the
사이즈가 나오는
94% oversize of the
Okay,
CT
here.
annual area.
Is this?
Yeah.
Yeah, this one.
Okay, very not much. Anyway, total calcium amount, and so the reason why actually we have no ideas in your current strategy of CT algorithm. Just Dr. Gang and Dr. Go had developed the area of sizing at least 10 to 15%, something like that. We don't have any idea, right?
yes.
So we want to match. It's almost the same. The reason why I want to choose for the recent concept, we choose less than 100%.
Right.
Size. Anyway.
Okay, let me introduce our nowadays algorithm. We usually try to the 10%, 15% oversizing, and that was developed on the basis of several consecutive cases. But 8 years ago, at the time, Sapien XT, we don't have a very concrete algorithm for the sizing matter. So 96% is relatively undersizing. If you're gonna rethink, it's on the basis of nowadays our algorithm. So I think the sizing matter would be one of the debatable part. So we can choose a 20 or 23. So.
What do you think?
So if you rely on the Bioprosthetic lab, but there was just the surgical valve information is available, not available for TAVR and TAVR valve, and so we discussed. I think prior valve 23 was undersizing, so 23 would be okay for this patient, and the 20 is also a good option. There was some debatable, the decision making.
Okay, great. I agree. 23.
Yes.
Anyway, just the main cause of AR is paravalvular regurgitation, and so just very pop-up suggests 20. I think it would be okay. Just treat the AR component. However, 23 is another option. However, more reasonable compared with the previous relatively small, proportion of annular size, and so depend on your reader.
Okay, I'm gonna start the procedure, and this patient is 88-year-old. TAVR failure is the 8 years ago, and the Sapien XT. So 이거 들어갈게. 지금 와이어 들어간 거지? 어디 TV? So usually this is the active wire, and then 오케이 됐다. 이 센터 좀 맞추고. For LV wiring, we have some the specific algorithm. First AL1, if failed AL2, and if failed JR caster. This is a soft teflon wire. 자, 오케이 센터 좀 맞추고. 오케이. 테프론 와이어지. 야, 역시 딱딱하게. Usually, and valve in valve wiring is sometimes difficult, and that is the same in the surgical valve. 우리 테프론 줘봐.
This is ring torque straight wire.
This is a ring torque.
stronger one.
오케이. 자, 조금만 더 옮길게. The valve itself is much sticky than the native valve, so LV wiring sometimes take time. 이게 AL1이죠.
네.
자, 베이스라인 루트 찍은 거 있어? 한번 보여주세요.
Let's check again the baseline root angiography.
Okay, AR over here. Okay, 요 같은 뷰죠 거의.
네.
This is ring torque wire.
이럴 때 있다.
Yes. 됐다. Okay, save. Yeah, sometimes if you're gonna do the valve in valve procedure, sometimes LV wiring much difficult than the native valve. Okay.
Although this is patient with AR, it takes time and some effort.
Okay, we're gonna do the direct.
This is Safari wire.
This is a Safari 2 and small curve.
Yeah.
Okay, over here.
Good.
And then the okay. 자, 여기서 한번 피그테일 줘보세요. And then we're gonna show the briefly hemodynamics, LV hemodynamics, and simultaneously pressure checking. That is our routine. 자, 들어갈게요. 딱 잡아. 오케이. 딱 잡아. straight.
Yeah.
straight. 자, 들어왔지?
네.
자, 여기서 오케이, pressure. 자, 이렇게 하고 오케이. over here. 오케이. and the flushing. And the Dr. Gang explained the LV hemodynamics.
Yes. The red line is the pressure from the LV, and green line is the pressure from the ascending aorta. You can see that the ascending aortic pressure is sloping down during the diastolic feed period. That means the aortic regurgitation.
Yes, looking at the LV pressure, there was a high LV EDP,
Yes.
and the AS component is just a minimum,
Yeah.
and the main component was a high LV EDP, and the diastolic, AR is a major component looking at this hemodynamics,
Yeah,
right?
you're right.
Okay.
Can you measure the AR index?
다 측정했죠? Okay. Okay, over here.
Wire.
So, and then I'm gonna put the Safari 2 wire again, and then we're gonna do the direct valve implantation. Previous Sapien XT. This is a Sapien 3. So, and the valve design some different. Also, one of the the big difference of Sapien XT, Sapien 3 is a basal shortening. So, if you're gonna consider basal shortening, I'm gonna initially more deeper position in the lower part of the Sapien XT. That is after implantation, lower bottom line would be matched well.
Yeah.
Also,
Also, another change is that the height of the valve is a little bit longer in ST, in Sapien 3, and there is the skirt in the basal plane that minimizes the leakage.
Okay, usually the Sapien XT in the half and half for height implantation, but Sapien 3 is a low part, is a basal shortening.
Yeah.
It's much larger than the upper part. There was some different part. Contamination 주의하고.
Yeah. The valve is ready. This is the 23 millimeter.
Could you show us again the sizing chart?
23 Sapien
1cc?
3
Okay. 사이징 차트 보여주세요.
with 1cc.
Okay, if you're gonna see the 23 prior stand was undersizing and the 1cc underfill, that means area oversizing is 20% oversizing. Okay, got it. And the wire 잘 잡고. 자, 잡았지? 됐어? 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 좀 더 가까이 딱 요만큼만. 자, 1, 2, 3 와이어. 1, 2, 3, 1, 2, 3. 자, 위에 좀 보여주고. 조금 더. 자, 여기서. 오케이.
밸브 라인은 프록시멀 디스탈 밸브 이렇게 퍼펜디큘러하게 보이는 뷰로 가는 게 훨씬 더 좋은 것 같아요.
네. 그러니까 저 뷰 이제 저기 플라나 뷰 맞는 뷰로 해서. 오케이, got it. Slowly. Okay. Okay. It's a propel scheme. It's cardiac surgeon is doing the modulation, manipulation of this, and he has also TAVR proctoring. Okay. Okay. 자, 조금만 더. 네. 조금만 더. 오케이, 됐습니다. 자, 이제 와이어 잡고요. 오케이, 이거나 들어갈게요. 살짝. 자, 그렇지. 또 더 만들고, 조금 더. 절반 돌렸죠? 오케이, 좋아요. 오케이, 좋아. 이제 피그테일, 요게 피그테일이지? 자, 코플라나. 어차피 그게 있으니까. T를 요 인플레이션 할 때는 이성아 쌤 조금만 빼주십시오.
네. 지금 빼겠습니다.
센터 맞추겠습니다. 자, 센터제. 자, 오케이. 와이어 잘 잡고. 약간 밑에가 베이잘 쇼트닝 생각해서 조금 더 들어갈 거야.
그럴게요.
자, 오케이. 좋아. 잠깐만. 천천히. 이렇게.
베이잘 라인보다 사실 조금 위여도 되겠더라고.
네. 이게 이제 베이잘 쇼트닝이 되니까 한 요 정도 맞춰야지 그 인프레션 하면 될 것 같습니다, 선생님.
오케이.
자, 잠깐만. 피그테일 좀 볼게. 위에. 됐어. 잠깐만. 자, 혈압 괜찮지? 천천히 가는 거 가더라도. 자, 테스트. 오케이, 이 정도. 자, 이렇게. 자, 준비됐지? 천천히. 자, 페이싱 온. 자, 컨트라스트. 됐다. 인플렛 쭉. 1, 2, 3, 4, 5. 디플릿. 오케이, 페이싱 업. 오케이, 좋았어. 천천히. 위치는 나쁘지 않아. 자, 1, 2, 3. 오케이.
Perfect position.
1, 2, 3. 천천히 하고 T. We're gonna check up T immediately. 오케이, got it. 오케이, 한번 T 좀 한번 볼까요?
네.
The blood pressure is stable and heart rate is about 50, 60 without AV block. Thorax is narrow.
오케이. 우리가 1cc 언더필 했어. 1cc 언더필.
1cc underfill.
노미널도 괜찮고 전혀.
네. Okay, and that is the TE benefit. Usually we do the MAC procedure, sometimes immediately check the transthoracic echo. Such complex case, still believe the TE would be helpful to evaluate immediate status.
So there is no AR from valve?
Wow.
No AR?
Yeah, no AR.
Absolutely no?
No. And we can check the paravalvular leakage from echocardiography, but there's no leakage. Paravalvular
Great.
leakage. Yeah.
Great. So, 여기 봐서는 아주 괜찮아 보인다, 그죠? 한번 그러면 저 T 이상에서는 이성화 쌤 없다는 얘기죠?
네.
이거 한번 찍어볼게요, 그러면. 오케이, 좀 낮추고.
Speak English.
Okay, got it. So over here, we're gonna check. 자, 준비됐죠? 자, 풀샷. 오, 너무 괜찮은데?
Great result. coronary opening is also good.
So I'm gonna recheck the the hemodynamics, elbow hemodynamics. Okay, 보자. 자, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1. I think most of audience very already familiar in the valve-in-valve surgical valve, but not yet fully familiar with the TAVR valve-in-valve. There was another obstacle for near future for is a reason why the valve TAVR indication is lower to much the younger generation.
Yeah. And some audience would be concerned about the durability issue of the TAVI valve. The patient received TAVI at 80 years old, and after 80 years, she's now 88, but still has to receive one more TAVI. And how about 10 years later?
So this patient 10 years later, 98.
Yeah. Yeah. Would another TAVI procedure be needed or not?
Okay. We check the LV hemodynamics.
So still, I believe the bigger the better.
Yes.
The previous stent had some, limitations.
Yeah, right.
Strong,
So
high pressures and.
Looking at the LV hemodynamics, there is many useful information inside. There are some big difference. And first, pressure gradient, even in valve, AS component nearly zero.
Yeah.
And looking at the previous one is a high LVEDP.
Yes.
Now LVEDP nearly horizontal, and the AR index at least more than 3.0. That means just a minimal, near zero AR. So you can definitely find that there is a big change of LV hemodynamics. There is a remarkable change. That is wonderful. Great. 다 레코딩 됐죠?
레코딩 됐습니다.
그다음에 이제 LV 요거 빼고,
네네.
그다음에 이제 한번 여기서도 T를 한번 체크해 볼게요. 자, 이승환 쌤 이제 밸브 안에 거 we removed all the wire and the cast from the LV, and could you check it up the T again?
Okay, we can see the no AR.
No AR. Wow, excellent.
Clear.
Yes.
And the opening is really good. There's no parabolic leakage.
Paravalvular leakage, yes. I think this case is a very representative case. Okay, so TE shows the excellent result. No AR, is a wide opening. So I'm gonna hear final checking, the angiogram. 자, TE 좀 한번 이승환 쌤 조금만 빼주세요. 자, 요거 이제 자, 준비됐죠? 오케이, 준비됐다. 자, 풀샷. 오, great. 그 다음에 아래 뷰. This is horizontal view. 오케이. T. 저 안 걸릴게. 여기 됐죠? 오케이. 자, 됐다. 자, 찍을게요. 인정. 자, 풀샷. Okay, LV diagram is perfect. So I think we learned a lot of things from this is previous TAVR valve-in-valve, and there are many lessons we learned from this case.
Great case.
Okay, Professor Essay, any valuable comment?
No, it's perfect. I really. Well, the only things, previous procedures when we did, actually we have no ideas, how big the stent selections. However, we've learned during the almost last 8 years some, CT algorithm, something like that. And we know everything, what we've done 80 years ago, and so we got to choose a little bit more, bigger 23. And even in the nominal size, high pressure, I think it's okay. Sometimes you know that we need some stent fracture for the, bigger area or something like that. And so it's great. Great cases, right? Nice demonstration.
Yes.
All right.
So in this case, we learned a lot of things. There are some sizing matter. How can the implantation depth and how decide to the TAVR, the modality, and we learned a lot of things. I think this case result was very excellent, and that was our future landscape of TAVR valve-in-valve, and this is a very nice representative case, and I hope the all audience and all discussion and panel enjoyed this case, and this is a very nice result. Thank you.
Great.
Thank you, everyone.
Great.
Thank you.
Thank you.
Thank you.
So we will now transition, I think, to the lectures. And the first, these are lectures on valve and valve TAVR. and the first lecture is going to be given by my co-moderator, Vinny Bapat. And Vinny is probably the world's expert in valve, really one of the pioneers and the person who developed the single most useful app in all of interventional cardiology. So Vinny, take it away on the optimal TAVR device for valve TAVR.
David, thank you very much for the kind introduction. And probably I'm the only surgeon on the panel. So again, gives me a great privilege to be among friends, virtual. I was hoping it would be in person this year. These are my disclosures. I obviously work with most valve companies. Valve design is my interest for many years. We have seen the valve-in-valve field exploding, really. It's aortic, mitral, pulmonic, tricuspid. We are doing it in rings and my MAC as well. So I think limiting the talk to optimal, just valve-in-valve aortic is probably the goal here. As you can see this on the screen, this is one of our very early patients in 2010 in St. Thomas's. This is fascinating. It's a very attractive treatment for sure. And now, of course, majority of them are performed through transfemoral approach. But very importantly, the confusion since 2010 is number of devices which are there. The number of devices have really exponentially increased. I'm sure some of you may or may not even remember some of them, but some have disappeared. But there are at least 9 devices currently in use. So what happens is each valve is pretty unique. And now we are going not from native valve, but we are now treating valve-in-valve as well. So it becomes a problem. In United States, it's slightly easier for us because we have only 2 valves at present. And if I look at which valve I would choose for a valve-in-valve, Sapien 3, of course, has a shorter profile, so easier coronary access if I'm in trouble. It's very easy to deploy. It's a very quick deployment, but it's not recapturable. So I have to rely heavily on pre-op planning for this device. And secondly, it's intraannular. So it has certain limitations in terms of PPM and in terms of rush and all effect. If I use a Evolut R, it's recapturable and repositionable to 80%, but sure, I think it gives me some advantage and some degree of comfort in certain situations. But at the same time, I can't align commissures anymore, and then coronary access might be heartbreaking for me. And then again, precise positioning takes a bit of time. And as we know sometimes that if you want to post-dilate, if your depth is not correct, you're going to embolize the valve. So again, certain nuances come into picture. So I think at present, valve-in-valve is approved for high risk. I would say it routinely happens in intermediate risk. But the reason I think this is very important is we have to understand durability, residual gradients, delayed coronary access, etc., and reoperations even, I would say, when we are choosing a particular valve today. And I think this is very important in this conversation. So in my mind, when I decide which valve I'm going to use, am I going to use Sapien valve or Evolut R, or in different regions of the world, maybe few other choices, I'm looking at, am I going to leave this patient with a patient processes mismatch? That's the first thing in my mind. Second is, am I going to cause coronary issues, obstruction on table or delayed obstruction? And thirdly, specialized situation is stentless valves, where really I think the strengths of different valves comes into picture. And honestly, maybe a platform like Lotus was a great for this because you could fully deploy it, check the fixation, check the coronaries, and then deploy. So I think we should definitely choose a device which will eliminate this risk or minimize those risks. So let's look at PPM after valve-in-valve. This is multifactorial. It depends, of course, on surgical valve size. We know very well. There's a rush and all effect because you're putting another valve inside, and there may be some strategies to eliminate that today. Transcatheter valve choice as well as position is very, very important. And I'm just going to show you 1 or 2 caveats about it. And let's not forget body surface area, because the whole calculation is based on body surface area. If you have a 19 size valve in an obese patient is different than a 19 size valve in a 50 kilo patient. So again, when I choose my device, sometimes I maybe choose intraannular device if the patient's demands are not that much. So ideal positioning is very important. And we have published this nearly 8 or 9 years ago now. And this is what we really need if we want to optimize hemodynamics. And I'm just going to show you an example of an early day core valve, which we had done in my center, which is on the right side, and an ideal position of a core valve, which of course is in the valve-in-valve app. So the image on the left side shows the ideal position, which is good fixation and best hemodynamics. And this is where the leaflets of core valve will be. That means these are true supraannular leaflets. However, the way we used to implant it early, because there was no recapturability, we were scared of embolization. And in this particular patient, obviously, you can see this is an intraannular implantation. So the whole advantage of the supraannular design has disappeared because our depth of implant was improper. In sapien valve, this is the case we have published many years ago. We showed that a top hat configuration is what is really important to give you lowest gradients. So if you deploy the sapien valve 50-50, it's not going to work very well. But if you deploy the valve exactly like this, which is 90-10, and this is the first generation sapien valve, this is what gives you the best hemodynamics. So these are the strategies to optimize or minimize the ppm, even if you are limited by other three factors. Russian doll effect is Russian doll effect. And honestly, you can't do anything else about it, but actually optimize it with something else, which is called valve fracture. And I'm going to just come to that a bit later. BSA is very important because we know that valves which are size 21 or less cause problems. And these are the valves where you should probably use a supraannular valve or consider valve fracture or do both of them. Valve fracture, as we all know, was introduced in Nordics and a great experience in the United States now. David is one of the three who has really led the charge and given us great guidelines on valve fracture. There are a lot of controversies still. We are still learning about valve fracture and the potential of it, I would say. When to do it? Should we do it before? Should we do it after? Is it safe? What precautions I would take, etc. But more importantly, valve fracture definitely reduces the Russian doll effect because that has been shown conclusively now. And there is a small worry about recoil, but I think surely and steadily evidence will show either way, if there is a recoil or not. Now, all valves, unfortunately, cannot be fractured, but I think in future, we will have designs like Inspiris, which may be expanded or easily fractured. And to be honest, there are more design features about this, which hopefully will be incorporated in all surgical valves as we see in future. Coronary obstruction is something which happens. And I think this happens, we know, in valves like mitral flow and trifecta. You can't do much about it. It is how it is. And I think in these, very important rule of thumb is look at the sinuses and VTC distance. This gives you a guidance more than anything, when to be cautious and when to be not. Basilica takes time at present, but I'm pretty sure in future, it will give us better, there will be better tools to do it. One of the things about it is if you do valve fracture, you are pushing the leaflets more near the coronary. So hypothetically, at least, there will be a more risk of coronary obstruction, but you are reducing the risk of PPM. So again, you have to choose what strategy you're going to use, and that may influence which TAVR device you're going to use as well. I think supraannular device, I'm not going to go in details, but coronary access can be challenging. But in future, I'm sure commissural alignment will come. And I think we need to understand CT scans better than what we do today. And I still feel that there is no all-or-none phenomena where you can't use a sapien valve and you can't use a core valve. This is just a very quick case example. This is a 70-year-old obese woman, very small size valve was implanted in her. A patient now came with bioprosthetic aortic valve stenosis. Dimensions are 17. This valve cannot be fractured. There's no base ring, but you can technically expand it a bit. You can see that the sinuses are effaced. The coronary distance is not very comforting. But here, we do a coronary angio and we decide to protect the right coronary. And then we decide to go with evolutar. The reason for that is hemodynamics. We want to give her the best hemodynamics, and we are ready to tackle any problem with coronary. So here, probably sapien would have been safer for coronary access, but we chose evolutar because we wanted better hemodynamics. And here in this patient, I'm just going to go quickly. After deployment, we could engage the guide very easily, and we didn't deploy any stent, and we got out. So we were cautious, we were prepared, and we chose the right valve for this patient. But on the other hand, this is another patient where we felt that we could use sapien very easily because we were still not sure about the coronaries, and this was a good size valve. So here we deployed the sapien slightly lower, and by doing that, we maintained the coronary access. So again, the choice could be either this or that. Stentless valves are very tricky. And although in St. Thomas's, we had huge experience of using sapien valve, we have now similar huge experience of using evolutar as well. And we use platforms such as Lotus as well. So I feel that a recapturable device might give you some comfort zone, especially in stentless when the sizing is not correct or the positioning is going to be very tricky. But if those two factors are clear, I think you can easily use a SAPIEN valve. So we use CT sizing and CT guidance in terms of implanting this valve. And then sometimes we use SAPIEN and many times we use Evolut. So just to summarize, as more devices come into market, the main question is not going to be what you use for TAVR. The main question also now is going to be what are you using for valve-in-valve? And I think we have to analyze the risk of PPM, risk of coronary obstruction, need for repositioning, and future coronary access if needed. And if those are the ones, they're equal, there's no concern at all, you can use any valve. But if you have certain concerns, then you should use an appropriate device as I've shown in the example. Thank you.
Thanks very much, Vinny. That's really a tour de force and lots of things to cover. I think we'll go to my lecture next, and then we will have hopefully a few minutes for discussion and questions, if that's okay.
Hi, okay.
Yes.
So may I ask a question?
Sneak one in, sure.
Okay, so so what is your strategy for the protection of the coronary, like the case before? You put a stent in. So is it your regular strategy, or you just put a Y in should be okay, or the balloon in should be okay? So what is your?
Yeah, right. I mean, that is just one of the cases I showed. It's not our regular strategy at all. I think of course, on CT planning and CT simulation, we use coronary protection in valve-in-valve, I would say in less than 10% of cases. And in these patients, we feel comfortable now that to engage a guide and leave a stent which is not deployed, and then only if necessary deploy the stent as a chimney fashion. The percentage of patients where we really need that is less than 3 to 4%. We don't need to deploy coronary stent in as many patients as we initially think. What we do now is, if we think that we don't need to deploy the stent, we put another guide, and then we see if we can re-engage the guide easily. If we can re-engage the guide easily, then we don't deploy the stent and we take it out. But if there is a difficulty in engaging the guide, then we go ahead and deploy the stent. Because the problem is, again, these patients can present delayed as well with some issue, and they go to another hospital, and they're going to face huge challenges in engaging the coronary if needed. And that's the logic behind it. If we deploy the stent, we anticoagulate these patients for at least 3 months. That's again our policy as well.
In our institute, actually, for the method for the coronary protection, we even though it is a limited case, we prefer the guidezilla. The reason why, the use of the balloon protection or stent protection, as Dr. Papat said, that in that case, the balloon is not used, stent was not deployed, therefore the reimburse was not done because the balloon was not used, stent was, so it is some expensive. So therefore we selected the guidezilla rather than the balloon or stent.
So you leave the guidezilla in the coronary the whole time, and then at the end of the case, you attempt to assess whether there's obstruction and need to advance a stent, as opposed to placing the stent prophylactically and pulling it back. Is that what you do?
And guidezilla even helps the stent when it is to be pulled, if it is not needed, in some calcified sinotubular junctions and the risk of the stent getting trapped. It's always good to use guidezilla when you are doing a coronary stent protection.
Another the consideration is that in case for the high risk of the coronary obstruction, we prefer the self-expandable like the Evolut rather than the SAPIEN. The reason why, as a structural type, that the SAPIEN is straight, so it's a high risk more obstruction. But when we select the self-expandable, there is some space in a sinus. So therefore, the true compression for the valve itself to the catheter might be lower.
That's a very good point, because SAPIEN valve flares out as well. And I think that's very important that one understand that. That's why I showed you the second case where we deployed the SAPIEN slightly lower for that very reason. As I said again, this is going to become a bigger issue when many valves are available. And I think it's multifactorial, and one of the biggest factors is your experience, what you're comfortable with as well.
I have one question to the Vinny. In case of coronary obstruction, do you use another guiding catheter to engage coronary ostium, or do you use the already engaged catheter?
The one which is already engaged. Yeah.
All right, should we move on to the last talk, Vinny?
Yep, absolutely. Please go ahead.
Okay. So I've been asked to talk about the other half of Vinny's talk is what to do when even if you choose the right valve, things are not going to work out right, and specifically about bioprosthetic valve fracture. These are my disclosures. So Vinny gave a great overview of valve and valve TAVR. We know that this is a relatively safe procedure that is much easier to recover from, and in high and intermediate risk patients in the United States, it's very commonly used. But the small surgical valves are really a challenge because of the Russian doll effect, as Vinny explained. And these are the data. This comes from the VIVID registry that Danny DeVere published about 6 years ago, and they really remain unchallenged, which show that in patients undergoing valve and valve TAVR, the patients who have a smaller valve, and in this case that was 21 millimeters or less by valve size, not the true ID, but the valve size, had a much worse prognosis over the first 12 months than patients with intermediate sized valves, 22 to 24, or the rare patient who gets a very large surgical aortic valve. And so this really has raised the concern about patient prosthesis mismatch, and was a lot of the motivation for developing the technique of bioprosthetic valve fracture. And so I'm going to try to cover in the next 10 minutes a couple of key points. First, just talk about the basic technique and the hemodynamic benefits in multi-center studies. I want to talk about several different advanced technical considerations, including valves that can't be fractured and what we might be able to do for those. Sizing and balloon sizing for these, timing issues with respect to when in the procedure to perform the valve fracture, and then finally when not to fracture valves. So we'll start with a case. This is a 71-year-old man, relatively young, with bioprosthetic valve degeneration. He had a CABG AVR in 2007 with a relatively small valve. This is a fairly large man. He had a 19 millimeter magna, which probably wasn't really great to begin with. He did fairly well, though, for the next 8 years, and then he began to notice increasing symptoms. Echo showed severe bioprosthetic aortic stenosis with a mean gradient of 60, and he was felt, despite the fact that he was relatively young, to be at high risk for repeat surgical AVR due to patent grafts, and in particular the proximity of the RV to the sternum. And so he was recommended for valve and valve TAVR by our heart team. This just shows the valve, the 19 millimeter magna. So this is a true ID of 17 millimeters. So you're starting pretty darn small. And so we were very concerned that whatever we did here, we were going to be left with patient prosthesis mismatch. The valve and valve app, if you look this up in Vinny's app, it says to use a 23 millimeter Evolute. But because we really felt that a 23 millimeter Evolute was going to be problematic, we were going to have a high gradient no matter what. We plan to do this with a 26 millimeter Evolute with valve fracture, given the small valve size. So we upsized the valve in anticipation that we were going to be doing a valve fracture no matter what. And so this is the actual case. These are the baseline hemodynamics, mean gradient of 63, valve area 0.8. You can see us doing the core valve Evolute in this case with the 26 millimeter valve. And after the 26 millimeter Evolute, not surprisingly, we still had a very high residual gradient, even though we got the valve reasonably high, mean gradient of 44 and a valve area of 1.0. And so at this point, we proceeded to do the valve fracture. Hopefully, most people have seen these at this point. This is a 20 millimeter true balloon, 3 millimeters oversized from the true ID. And you can see here the valve release at the point when it fractures. And the valve gradient was reduced now from the 43 that it was after TAVR to 18, a muto much more satisfying result with a valve area of 1.9 centimeters squared. So a nice, successful valve and valve TAVR with the bioprosthetic valve fracture. Just to remind people how you do this, these are the 4 pieces of equipment that you need. You need a coronary indiflator, you need a large volume reservoir, a syringe with dilute contrast, you need 1 high pressure stopcock, and then you need a balloon that can accommodate very high pressures. The one that we prefer in the United States is the true dilatation balloon, which is Kevlar wrapped. That's not generally available in some countries in Asia in particular, but the Atlas or Atlas Gold balloons made by the same company are also Kevlar wrapped and can tolerate very high pressures, although they are all off-label. The setup that we use involves hooking the large syringe reservoir to the coronary indiflator through the 3-way stopcock, and then that entire assembly to the back end of the true balloon. You can see when we start, the coronary, the stopcock is turned off to the indiflator. And the first step is to hand inflate the balloon. You can generate about 3 to 4 atmospheres pressure with a hand inflation with a large syringe. And then as soon as you've run into obstruction, you can't inflate it anymore. You quickly just turn this stopcock, and then you continue to inflate using the indiflator, watching the pressure gauge until something happens. And the something that happens is usually that the valve fractures. When the valve fractures, you can often see the release. You will also see the pressure very quickly drop. And there's only 2 reasons the pressure quickly drops. Either the valve has fractured or the balloon has fractured. Either one of those is a reason to stop inflating at that point. So that is the basic procedure. The way that these valve fracture, we've learned a lot about this. Keith Allen, my former surgical colleague, and Adnan Chachawala really did a lot of the basic bench research to see what exactly happens. And what happens when you fracture the valve is there's generally a single point break. This is a Magna valve, which is a very nice one. You can see it very clearly. The rest of the sewing ring is intact. And if you take the valve, this is a different valve, the Sorin mitral flow, but if you cut into it and see what has happened, there is this plastic sewing ring inside the Dacron cuff, and that has broken in a single spot. And that's what really happens when you do the valve fracture. The hemodynamics are why we do this. These are a multi-center series of about 10 centers in the United States. The first 66 patients who underwent valve and valve TAVR, followed by bioprosthetic valve fractures. You could see the stepwise change in the hemodynamics. So baseline 40 millimeters of mercury gradient. After valve and valve TAVR, still a relatively high gradient of 19, and after valve fracture, an average of 8. And you can see a similar stepwise increase in the mean effective orifice area. So again, a very gratifying improvement as you step through the procedure. As Vinny mentioned very briefly, one of the things we learned, fortunately at the bench and not the hard way in the patient, is that there are some valves that can be fractured. Most of them can, but not all valves can be fractured. So here is a list of the valves that can be fractured. The ones that are most common in the United States that we see are Magnas, MitraFlows, and Mosaics. Those can all be fractured. The perimount, that's the newer generation perimount that looks like a Magna with a perforated ribbon, can also be fractured. And the Inspiris is the new valve from Edwards that is meant to be fractured. Then there's a series of valves that can't be fractured but can be remodeled. And I'm going to talk about that in just a second, including a couple of the Carpentier Edwards, the older generation perimount that Vinny just showed. And very commonly in the United States, we see a lot of trifecta valves, and those cannot be fractured, but they can be remodeled. And then there are 2 valves that you can't do anything to. These are the Avalis valve and the Hancock 2 valve. These ones you have to manage either surgically, or you have to do a really good job in planning the valve, because you're not going to have any way to rescue the case if you get bad patient prosthesis mismatch. So what is bioprosthetic valve remodeling? Again, I'm going to show you an example. This is a 21 millimeter trifecta valve with a true ID of 19. We did a valve and valve TAVR with a 23 millimeter Evolute R. And at that point, there was still a residual mean gradient of 29 millimeters of mercury and an aortic valve area of 1.0 centimeters squared. So we decided in this case, even though we can't fracture the valve, to do what we call remodeling, which is basically reshaping it. And you can see that's what's going on here. And so you'll see with the true balloon being inflated to a moderate pressure, not to super high pressure, what happens is the supraannular region expands, but the area down here right by the annulus still remains constrained. And that's what we mean by remodel. It's expanding the supraannular area. There is some recoil, but you can see in this case, the valve gradient was reduced. It went from 29 down to 13 millimeters of mercury just by flaring out the core valve in this case. And you can do the same thing with a sapien valve. If you're going to be doing any of these balloon maneuvers after the valve has already been placed, you have to be very careful, in particular with a self-expanding valve, about the valve size, because if you put too large of a valve up into the valve apparatus itself rather than just down at the annulus, you can tear one of the leaflets. Keep in mind that with valve fracture, you want to employ, the constraint is at the valve ring. And so you want to keep the valve low. In fact, you can just position most of the valve in the LV outflow tract. And that way you can oversize the valve if you need to, because you're not going to be anywhere up near the valve leaflets. On the other hand, with bioprosthetic valve remodeling, the constraint that you're trying to address is at the level of the valve frame. And so you need to keep the balloon higher, and you really need to respect these maximum sizes, which the Medtronic has very nicely provided for us. One of the remaining questions that we really don't know the answer to, that Vinny alluded to, is whether it's better to perform the valve fracture before or after you do the valve and valve TAVR. So the BVF first, fracturing the valve before you put in the TAVR valve. The pro here is that you never have to do a high pressure inflation in the new transcatheter heart valve, which at least some people have posited might lead to accelerated degeneration, although others point out that the crimping that you do also applies a lot of pressure to the valve tissue. So it's not so clear that this really is an additional insult. The con of doing the BVF first is that by fracturing the valve before you have any frame inside of it, there is increased risk potentially for leaflet embolization if you really tear a leaflet, or acute severe AI with hemodynamic compromise. So if you're going to do this, you really need to be ready to go with your TAVR valve before you get started with the valve fracture. The BVF second is the one that we have generally done. The pros here, one of the biggest ones, is you can decide whether you need to do it or not, because you can assess the hemodynamic results before deciding to perform the valve fracture, and the high pressure inflation at the end assures that the heart valve is optimally expanded. But on the other hand, as I mentioned, the high pressure inflation could theoretically lead to acute or subacute injury to the transcatheter valve. So really, there are pros and cons of both approaches, and we honestly don't know the answer. I think you can pick one and kind of stick with it and get good at it. Last point I want to make is when you shouldn't fracture. Obviously, you shouldn't fracture if you don't need to, because there are complications associated with everything. We don't fracture surgical valves that can't be fractured. Again, these are the Hancock 2 and the Avalis. We don't fracture if there's increased concern for coronary occlusion. So you really want to do what Vinny showed of assessing the virtual transcatheter valve to coronary distance. And if you predict after expansion of the transcatheter heart valve that you're going to be within 3 millimeters or so of the coronary, then either coronary protection or basilica is a very reasonable step, because that's getting pretty close to coronary occlusion. If you have a very small STJ or LV outflow tract, you really want to make sure there isn't a lot of calcium there that could lead to rupture if you apply a lot of force to that area. And finally, in patients who had prior root enlargements or root replacements, don't try. Very high risk of root rupture, and I think that would be a very dangerous procedure. So just to finish up, a couple of final points. For patients with small bioprosthetic valves who are high risk for redo AVR, we think that bioprosthetic valve fracture or remodeling may at least offer a partial solution to these high residual gradients after valve implantation. Fortunately, most contemporary surgical valves can be fractured or at least remodeled, and the newest valves are actually built to accommodate this. Our clinical experience in our center with at least 100 of these procedures and many other centers that have adopted it now suggests the procedure is generally safe, although it is certainly not entirely risk-free. All the complications that can happen with traditional TAVR can happen with valve-in-valve TAVR with bioprosthetic valve fracture. And I think the unresolved questions at this point is the timing, which is better pre or post. Does that impact on long-term outcomes? And whether we should be doing, bioprosthetic valve fracture on all procedures in order to optimize expansion of the transcatheter valves. These are unresolved questions. We're probably not going to get randomized trials, so we're going to have to hopefully collect some real-world registry data and study it carefully to understand the implications. Thanks very much.
Thank you, David. This was a great talk and great summary. And I just want to kickstart while others are thinking of questions is, I think this is very relevant now, is pre-fracture or post-fracture. And our strategy has always been pre-fracture. But we add a small caveat to it, is when we pre-fracture, we always post-dilate with the same balloon, because at that point, it's at a very low pressure and it optimizes the dimension. And, we have seen that from animal heart experiments, etc., that's probably a way to go. I just wanted your views, because in old days we used to fracture, but we never used to post-dilate it to optimize the benefit.
I think that's a very reasonable way to go, Keith. We've done some post hoc analyses of our multi-center data, and it does suggest that a final post-dilation, whether that be accomplished with with the final, if you're fracturing at the end or if you're fracturing at the beginning to finish up with it, it does seem to get better hemodynamics. So I think that's very reasonable. Why do you choose to pre-fracture? Is it worry about the damage to the leaflets? Is that the main reason?
So absolutely. I think that's because it's a high pressure. And as a surgeon, I see what high pressure dilatation does when I use Sapien in MAC. That's the time when actually you can see the whole grid imprinted on the leaflet. So, and with the whole thing about halt, and I just feel more comfortable if I can avoid it. And to be honest, sure, we were worried about severe AI as one of the issues. Actually, it doesn't happen as frequently as other complications can happen. However, this is a small number in experience. And as we go ahead, and I would like to ask the panelists what they prefer in terms of fracture and before or after. Dr. An?
Yeah, actually, initially in our centers, we performed after the fracture with David Cohen. So but I don't know. Actually, I don't have enough idea about which is better than the other.
I feel like I probably did all the fractures in your center, so they all were done after. I don't know.
Yeah.
Dr. Flaherty, what's your experience and strategy?
We had this fear that you alluded to, that we could make the patient very sick if we did it before. So we got in the habit of doing it after. And now I think there's thought of, well, is that worse for the leaflets? So I'm open to reassessing our practice, but we have traditionally done it after. And I don't know if that's the right thing or not.
Yeah, I mean, I think if you could do it safely before, it's clearly nicer because you don't have to worry about the high pressure, whatever the theoretical concerns are and the imprint of the frame on the leaflets, it's nice. And so if I would say the real question there is, what does the multi-center data tell us about the safety of pre? That's probably the clear way to go.
And the other important real issue, which we'll be addressing soon, is if you are fracturing, what size TAVR device to use. Now, that's also very important in terms of optimizing many things. And it's not very clear because every surgical valve is different. So the diameter you gain can be very, very different. And we have shown in experiments now, and actually some of the clinical cases where inadvertently we not just fractured the valve, but we actually destroyed the valve. That means we ruptured even through the sewing ring. So these are some of the things we really need to understand. And these have happened in expert centers. When people send me cases I review, fluoroscopic appearance of valves is very different than actual stent frame. So for example, mitral flow, what you see is the sewing ring. So if you see the mitral flow radio opacity being fractured, that means you have destroyed the valve.
Yeah, that one you don't usually, that's a hard one to see. I think, what our usual rule of thumb is, based on just purely averages, as you say, they all just respond differently. And sometimes it might just be the aortic root that changes, as well, not just the valve. Is we know that they tend to grow about 3 to 4 millimeters on average on the bench. That's what we've seen on the bench. And so we tend to use that as a, rough guideline for sizing the valve that we implant. We implant a valve, if the true ID is 19, and we're going to fracture that valve, we estimate we're going to end up around a true ID of 22. And so we go to the Valve and Valve app, and we can look up what size of valve we should use for this prosthesis with a 22 true ID, and we'll use that. But it's definitely not exact. It would be nice to know better.
Professor Wong, in China, are you fracturing surgical valves?
Yes, but not many cases. So actually, most the surgical valve cannot be fractured.
Which valves? Because you use the ones that can't be fractured. What surgical valves are common in China?
St. John, most are St. John.
Trifecta, right?
Trifecta, yeah, that one. Yeah, that's they're very common in the U.S. as well. Yeah.
So, David, may I have a question also for the all panelists? So, what is the country education for fracture of device? Do you have any country education? To
me, I tried to say them at the end there. So one, obviously the valves that truly can't be fractured, where it's pointless. All you'll do is rupture the balloon. That's number one. Number two is if the risk of coronary obstruction is very high. Then you need to think, very hard about whether you should be doing valve and valve to begin with. Or, is there, again, you may have to do basilica or something like that to prepare it. And then the third is a root replacement. So if they've had a root replacement or a root enlargement, don't try. Those are the three biggest ones to me.
Otherwise, what about, David, as you said, large valves.
If the valve, if he doesn't need it, it doesn't need it.
Means so, if you have a size 27 or large in comparison to what patient needs, I think that's and the Inspiris design explains it, because Inspiris is expandable only from 19 to 25. 27, 29 are not expandable. And the reason behind it is, if you have reached that level, you are going to need maybe 34 revolute hour. You don't need to fracture.
Yeah, there's so few of those, so it doesn't come up very often. I don't think I've ever seen it. Again, maybe it's because they're so large, they don't come back for valve and valve, because I've never seen a 27 millimeter surgical valve in a patient being referred for TAVR. So
that's
what is the experience of fracture in the mitral position? Speakers.
I'll say a little bit. Maybe Vinny has more. There are reports of it. It's doable. in the normal way. Again, the mitral valves tend to be much larger, and so you can fracture your way out of being able to fit a sapien valve into it. But we've done one or two. We've actually done it in a tricuspid as well for it. So the mitral annulus will accommodate it in most cases. Again, unless there's very severe MAC or something like that, which would be then I would never touch it in those cases. But it is fracturable in those if you have a unacceptable residual gradient. Vinny, what's your experience been?
Yeah, I mean, I think the biggest true balloon we have is 28 size. So that's the main limitation, I would say. Most of the time when we need the fracture in mitral, it's done after sapien is implanted, because the advantage of that being it reduces the diameter further. So we have, again, not just in mitral, but in aortic bench testing on animal hearts, actually, what we have shown is once you implant the valve inside, the advantage is you can fracture with a smaller balloon.
So it's like building a landing zone like you do for a
so that kind of gives you a bit of, on mitral, some advantage, I would say, that you're going to fracture. Interestingly, we have fractured some surgical mitral valves in open surgery in a very high-risk hybrid patient, which we showed last year, and 2 or 3 more done in Colombia, where for a variety of reasons, we wanted to keep the procedure really quick on heart-lung machine. So what we did was we went in, we cut the leaflets out, but with a knife, we cut the stent frame so we could expand it a bit more. So again, we are extrapolating a lot of experience from transcatheter world to open and other way around as well. But this is going to be a very interesting field, I think, and we need bigger balloons, I would say, David, isn't it?
Yeah, well, it doesn't seem like there should be major limitations to building us bigger balloons. I think that should be the least of the problems. But who knew when you started making the valve and valve app 10 years ago that it would turn out to be this important and this big of a field? I think
that is very true. And what's the situation in Korea and Taiwan? Do you have access to true balloons which you use for fracture?
All I know is that I had to bring them in my suitcase every time I came to Korea to do them. So I'm not sure they're. Don't tell the authorities from it. So I think they have the Atlas, but not the True. For that. Well, I think we're being asked to sort of wrap up our session. It's been a great evening over here, and hopefully morning in Asia. And I really appreciate everybody's contributions. Certainly some wonderful cases from Asan Medical Center of bicuspid valves that we got to witness, and then I think some really interesting didactics on valve and valve therapies. And I want to wish everybody a safe summer, and we look forward to seeing everybody as soon as possible, if not at TVT coming up, hopefully at TCT in the fall, or next year in Korea. I think all of the above. Thanks, Vinny, for your help.
Good night, and it was a pleasure to meet everyone. Bye-bye.
Have a great evening.
Thank you.
Take care.
Thank you.